Hi, I'm Sevastjan Kranz. I'm an anatomical pathologist at Royal Melbourne Hospital. Head and neck pathology, it's one of my specialty areas, which I've been doing for a good few years now. And I've been very kindly invited to be a part of the Tongue Cancer Symposium and to present. So in this recording, I'll be covering the pathological assessment of tongue cancer. And it should hopefully be useful to pathologists in dealing with some of the trickier elements in assessment, but also for clinicians as well, to get a bit more of an idea of what goes on in the lab and maybe some of the challenges which pathologists face. So anyone can go to the websites of these organisations and they can look up the cancer protocols and the guides in assessing tongue cancer. And you'll come up with a list which looks like this. The issue with those protocols, though, is they don't really have much practical details on how to actually assess these things. And in my experience, sometimes it's not quite as straightforward as what it's suggested. In particular, depth of invasion, it can be really quite challenging in practice. So I'll be going into a little bit more depth of the difficulties in these assessments and how I overcome them. But before I get into that, in case there's anyone who's watching who doesn't have experience within a lab, I'll just briefly touch on how specimens are processed. So this is a typical tongue cancer specimen. We can see there's dorsal tongue here. On the lateral aspect, we've got the tongue cancer, and then we've got a little bit of attached mandible. So they come fixed in formalin, usually overnight, and that preserves the tissue and it firms it up. So it allows us to section through it a lot easier. Another specimen here with the lateral tongue tumour there also has attached mandible. This one also has some submandibular gland and a bit of neck dissection attached. So what we do is ink up the margins in different colours so we can tell under the microscope where those margins are. Dissect off the bone, which is then placed into decalcifying solution, a strong acid, which softens up the bone so it can be sliced later. And then we slice through the tongue in a fashion which we call bread loafing. So we end up with these slices laid out consecutively. They're about 3 millimeters thick. And we can see the tongue cancer around here. And then those slices, they're cut up into smaller pieces, which are then processed into slides, noting the different slide numbers, which really helps with reconstructing the tumour under the microscope. And it also helps if there is, say, a close margin. We can go back and look at the exact slide and tell on the specimen exactly where that close margin is. And so then we can go back to the surgeons and say where that is. When we're talking about tongue cancer, we're almost always talking about conventional squamous cell carcinoma. So the vast majority are conventional SCC. There are some variants of SCC, and I will go over Varucas carcinoma, but the rest of them and these other tumours here are really quite rare. So in the interest of time, I won't go into them. So conventional SCC, it's usually not a difficult diagnosis for pathologists to make. So this is a typical appearing one. We've got normal mucosa along the top. We've got the tumour here. It's invaded down from the mucosa into the stroma, into skeletal muscle as well. And it's quite histologically distinct, quite pink with all this keratin here. This is another tumour. We can see the normal mucosa here and then the tumour here. And it's got a lot of invasion into the stroma here. And this is really one of the keys for conventional SCC is these little irregular jagged nests invading into the stroma and having a stromal reaction. And then zooming in even closer, typical for carcinomas, there's a lot of nuclear atypia. So we can see quite large irregular nuclei, quite a few mitoses around, and characteristic of squamous cell carcinoma, we've got little bits of keratin there too, which is this dark pink colour. So conventional SCC is quite an easy diagnosis to make, but Varucas carcinoma is not. It usually gives pathologists quite a lot of grief. And while it is uncommon, it's probably the second most frequently seen subtype of tongue cancer that I see. It's a well-differentiated, non-metastasizing variant of SCC, and clinically it has quite a warty appearance. So this is what it usually looks like under the microscope. On the surface, we've got this warty appearance, quite irregular, filiform. We have these sharp spikes here, which are described as church spires. Quite a lot of this pink keratin. But the key really to Varucas carcinoma is deep pushing invasion. So we can see these deep, broad pushing rete down here. And what we like to do is compare that to adjacent normal mucosa. We've got a little bit here with the tumour undermining it. Off the edge of the photo here, also normal mucosa. So it's going down deep endophytic growth. And then looking closer at those rete, we can see that it's got a nice rounded edge, kind of broad base, described as being a lot like elephant feet. And compared to that conventional SCC, which had those little irregular jagged nests and a kind of stromal reaction, this has got a nice kind of rounded edge to it. And then going in even closer, we can see that there isn't really much nuclear atypia at all, which is also a key to making the diagnosis of Varucas carcinoma. So this is a typical example of a biopsy of a Varucas lesion, which is quite difficult. So even though it is quite a generous biopsy, there isn't really any adjacent normal mucosa to compare to. And so we can't really tell if there is deep pushing invasion or if this lesion is predominantly exophytic, in which in that case it would be Varucas hyperplasia rather than carcinoma. And so zooming in a bit closer, it does have that Varucas appearance with a regular surface, kind of broad rete. But don't have much stroma and can't really tell if it has that pushing invasion. So if there's any surgeons watching, and if you've got a Varucas lesion which you're going to take a biopsy of, it really helps out pathologists to try and take a bit of normal adjacent mucosa and get a little bit of stroma as well underneath it. Even when we do get that though, it really is quite a difficult diagnosis, and it's not unusual to have to require a complete excision of the lesion to make the diagnosis of Varucas carcinoma. This is another biopsy of a Varucas appearing lesion, and we can see on the surface it has that irregular warty appearance. Going to the deep aspect of it, we can see that there's not really much stroma at all, but despite that, it doesn't really have that kind of deep pushing, broad-based rete, which we were seeing in the Varucas carcinoma. It's kind of irregular and jagged, so it doesn't really fit with Varucas carcinoma. And then zooming in even closer, we've got quite a lot of nuclear atypia, and so they're all kind of jumbled up. There's quite a few mitoses in here. So that really is incompatible with Varucas carcinoma. So not infrequently, some pathologists, they get a little bit misled by Varucas appearing lesions, and conventional squamous cell carcinoma sometimes can have this Varucas appearance on the surface, and it's important not to misdiagnose. Another important thing to be aware of is that you can get conventional squamous cell carcinoma arise in Varucas carcinoma. So you can get something which looks like Varucas carcinoma on the biopsy, and then in the complete excision get a conventional SCC. So moving on to tumour size, it's quite important for staging. And the cutoffs are at 20 millimeters and 40 millimeters. Usually doesn't give us too many issues at all. And most of the time we use the macroscopic measurement. So typically like this, we can see a really clearly demarcated tumour, and then just with the ruler, we measure it. When the tumour size is around that 20 millimeter or 40 millimeter cutoff, it is important to take multiple measurements of different slices just to be certain of which category it does sit within. Sometimes though, the macroscopic appearance is not very clear. Like in here, we can see that the mucosa is thickened, but then we've got this kind of hazy, irregular, cream-coloured lesion, and it's really difficult to tell macroscopically whether or not this is tumour, is it fibrosis, is it inflammation, and then we really do need to measure it microscopically. Another instance when we need to measure microscopically is when you've got a large plaque which turns out to be predominantly dysplasia, and then you just get a little focus of microinvasion. And so the way in which I measure microscopically is I've got a camera attached to my microscope, and I've got a calibrated digital ruler which I use, and it really makes the measurement quite easy. I do the same with depth of invasion, and also if there's any close margins, I use the camera with a calibrated ruler to make a measurement. If you don't have that, you can get a transparent ruler of acetate paper, which can just be overlaid on the slide, and then you can look down the microscope and get a clear measurement there. Some pathologists, they use the diameter of the field of view. So when you're looking down the microscope, you have a big circle, and depending on the magnification, it's a certain diameter across. And then you can kind of estimate based upon how far it is in that field of view, the size. I really don't recommend doing that. It can be pretty inaccurate. For a larger tumour, where you do need to take the microscopic measurement from the slide itself, I use the really high-tech method of looking down the microscope right at the border of the tumour, and then putting little dots around where that is, and kind of marking the outline of the tumour then. And then just getting a ruler and kind of overlaying that on top of the slide and then taking a measurement there. It's not the greatest method for smaller tumours because you can be out by a millimetre or two, but for larger tumours, it can be okay. So depth of invasion, it's become particularly important with the 8th edition of the AJCC staging manual, where it's been incorporated into the T category of staging. And in that manual, the 8th edition, it has clarified that depth of invasion is not just tumour thickness. And so important cutoffs are 5 millimeters and 10 millimeters. And so the way in which we make the measurement of depth of invasion is in adjacent normal. What we do is go to the basement membrane, and then we kind of draw across from normal to normal, make a plumb line down at the deepest invasion, and then that's your depth of invasion, compared to tumour thickness, where you just take the whole thickness of the tumour. And so when you do have quite a lot of an exophytic tumour, the depth of invasion can be a little bit less than the tumour thickness. And the reason why we use depth of invasion now is it's thought to be a better predictive parameter for prognosis. Though there has been some papers which have come out, in particular this one by Salama, which suggest that there really isn't much of a practical difference in prognosis between tumour thickness and depth of invasion. So maybe in future we will go towards tumour thickness, but at the moment we are using depth of invasion. So most of the cancer protocols and staging manuals use schematics like this, where you draw a horizontal line from normal mucosa across and then down. The issue is oral mucosa isn't dead straight. There's a lot of curved contours, there's a lot of lumps and bumps. So in practice, it's not usually as easy as what it's suggested in the schematics. And there have been a few recent articles, including that Salama article and these ones here, which address a lot of the issues which come up with measuring depth of invasion, and they have some workarounds as far as depth of invasion assessment go. So I'll go into a few examples of depth of invasion. This one's fairly straightforward. So we've got the normal mucosa here. There is a little bit of ulceration here, and then we just kind of draw a line straight across and then a plumb line down and make that depth of invasion measurement there. This is an example of a very ulcerated tumour and shows how it can affect the depth of invasion measurement. This is a pretty large image, actually. It's got quite a few photos kind of stitched together. And so under the microscope, a field of view would only be in about that region there. So in cases like this, what I like to do is draw along the top on the slide with pen where the normal mucosa would lie, and then that makes the measurement down to get the depth of invasion a lot easier. This is an example of curved mucosa. So we can see the normal mucosa up here. There's mucosa down here, partially eroded, but otherwise normal. And if we follow the staging manual, what you would do is just draw a straight line all the way across and then a plumb line straight down there to get the depth of invasion. But no one's mouth really looks like this. There isn't any kind of straight jagged lines like that. So a lot of the more recent recommendations now are to draw, or kind of mentally draw in a curvilinear line, reproducing where that basement membrane would lie or would realistically lie, and then measure down the depth of invasion, which seems to make a lot more sense to me. Depth of invasion is also supposed to account for exophytic tumours and not overstate how far down they actually invade. However, there's cases like this where we do have an exophytic tumour, but what happens is the tumour just kind of gathers the normal mucosa around it and kind of pulls it up and pushes it out. And so this is the slide of that case. And you can see if the tumour wasn't there, the normal mucosa would kind of track along here, but the tumour itself has kind of gathered up the mucosa and it's pushed out. And so in the staging manuals, it's not very clear on how to take the depth of invasion here. So in current recommendations, what you would do is kind of measure across here where the basement membrane would lie, and then take a depth of invasion from that. This slide also illustrates one of the common issues with taking depth of invasion measurements, in that most tumours are really quite large and you can't really fit them in a single slide. You can only get about 2 centimetres on a slide. So getting normal mucosa on either side of a tumour is really not possible. So drawing in where that basement membrane would most likely sit is the best recommendation at the moment. Another common issue is the mucosal irregularity, which you get at the border of the lateral tongue when it turns into the floor of mouth. And we can see here the floor of mouth coming off at a different angle. This is the edge of the tongue, the border of the tongue. Thankfully, this one isn't too difficult. We've got the normal mucosa here and here, and then we can just draw a line straight across and then get the depth of invasion down. This is another one from the border of the lateral tongue, and this one's not quite as easy. You can see the floor of mouth mucosa kind of comes off at a 90-degree angle. So measuring from the base of it, there where the normal mucosa kind of starts, it doesn't really make much sense because you would end up with a depth of invasion of 0. It's also quite hard to imagine where the basement membrane would actually really lie. Possibly it's kind of around this region, but it's really hard to tell. So some of those papers, which I showed previously, they recommend just taking tumour thickness in these instances. So pattern of invasive front, it's not quite as important as some of the other features in this talk. But I have noticed that some people are a little bit confused about the classification. And that is fair enough. So there is worst pattern of invasion. There's 5 different patterns. And broadly, you can group pattern 1 through 3 into this cohesive group here. And so what that comprises of is invasion with large pushing finger-like growths, large islands of cells which are greater than 15 cells in size. Then you've got pattern 4, which is this non-cohesive group here, and that has small infiltrative nests which are less than 15 cells in size. And then the actual one which you really need to pick up on is this pattern 5. And so that one has microsatellites which are greater than 1 millimeter away from the main tumour focus. And the way in which you classify this is by picking out the worst pattern of invasion, and then it kind of falls into those categories. So briefly just going through the appearances of them. This is a cohesive type of invasion where we've got finger-like growths and these large tumour islands. Pattern 4, where we've got these small infiltrative nests. And then zooming in, you can see that those nests are less than 15 cells in size. And this is the pattern of invasion which has microsatellites. So up the top here, we can see the main tumour focus, and then we've got microsatellite out here which is greater than 1 millimeter away from the main tumour focus. And so what comes with that is a poor prognosis. So these tumours which have a pattern of invasion like this tend to have more likely have lymphovascular invasion, tend to get closer margins, and they're more likely to have nodal metastases. And this is just another example of the microsatellite. So a bit of the main tumour focus here, and then a microsatellite well away from that main tumour. So bone invasion, it's important for staging. When it is present, it bumps it up into stage T4A. This is the case here. Usually with tongue cancer, it needs to be quite big before it invades bone. What's happened is we've stripped away the soft tissue from the bone, and we can see that the tumour there has invaded through on the lingual surface of the mandible. And so that bone then is placed into decalcifying solution. A few weeks later, it's soft enough to cut. We've got it in serial sections here, and we can clearly see that there's a lot of bony destruction there from the tumour. But we do have to confirm that there is bone invasion histologically. So in the slides, to confirm bone invasion, what we really need is tumour going through the cortex into the medulla. So we've got tumour up the top here, the cortex of the bone, which is around here, and that has been destroyed by the tumour. And then we've got tumour invading down into the medullary space. So zooming in, we can see it in the medulla there. So tumour nests in between the bony trabeculae of the medulla. I also like to take note of whether or not the inferior alveolar nerve is involved. In this case here, we've got the tumour adjacent to it, the nerve here, and it's not involved. And also need to document the bone margins. And so what we like is 10 millimeters either side of involved bone. A potential trap for assessing for bone invasion is getting cortical erosion only. So we've got a case here, and usually, like with this instance, you get cortical erosion adjacent to teeth or around the tooth socket. So we've got tooth here, we've got the tumour up here, and then cortical bone here. And then zooming in, we can see that it really is just kind of cortical erosion. We're not seeing tumour getting down through the cortex into the medulla. So this doesn't count as bone invasion. Lymphovascular invasion, it's when we see tumour invading into blood vessels and lymphatics. Obviously important to pick up, as the tumour definitely has metastatic potential then. Usually we find lymphovascular invasion around the border of the invasive front of the tumour. In this case, it's pretty straightforward. But what you really need for lymphovascular invasion is to see a tumour plug within an endothelial cell line space. We can see that this is lymphatics here. So we've got a vessel with this kind of hazy proteinaceous fluid, lymphocytes within it, tumour plug here, and we can see that there's definitely endothelial cells around. So definite lymphovascular invasion. A pretty common difficulty though is trying to distinguish tissue retraction from actual lymphovascular invasion. And so when the tissue fixes, what happens is you can get contraction, and the planes of the planes of the tissue can separate out, and then you can get this kind of clearing of spaces here. And you can get the same thing around tumour nests. So it can make it really quite difficult. And so zooming in on this, we can see the tumour plug there. Possibly we've got some endothelial cells here. And so if you're not quite sure, it can be helpful to do some vascular markers by immunohistochemistry. So we've got ERG, which is a marker for endothelial cell nuclei, which it's staining up there, as well as D240, which stains the cytoplasm of lymphatic endothelial cells. So we can confirm that that actually is a case of lymphovascular invasion. This is another case where we've got a tumour nest with some clearing around it, potentially have an endothelial cell here, but it's not definite. And so immunostains help in this case, showing that no, it actually isn't lymphovascular invasion, but it is tissue retraction. And another example where we've got a tumour nest here, we've got some clearing around it. But in this case, we're not really seeing anything which looks like endothelial cells. So this is a case of tissue retraction, which may be mistaken for lymphovascular invasion. Perineural invasion, it's associated with poor local and regional control of the tumour, and it does guide decisions regarding the therapy. So picking it up, typically what I tend to see is it's around the peripheral border of the invasive front of the tumour, like lymphovascular invasion. And P&I, it's reported regardless of the nerve size involved. So this one here, it's a small nerve with a little bit of tumour wrapping around it here. I do tend to document the the size of the nerve involved. And extratumoral foci of PNI, which we see here, where it's a nerve which is well beyond the main tumour focus, quite important to pick up because it has even worse prognosis. So margin assessment at Royal Melbourne Hospital, what we like to see is tumour greater than 5 millimetres away from margins. Most of the time, it is really well clear, and we can tell macroscopically, like in this case here. So what we have is the tumour focus here and margins around, and then macroscopically we can measure with a ruler. We do confirm with the slides though, just to make sure that it is really clear. Sometimes the tumour is a little bit closer to the margins, and then I do measure microscopically, like here. So we can see the tumour creeping into field here, inked margin on this side here, and then I've used the digital ruler with a camera to measure. Unfortunately, some cases the tumour does extend beyond where it was expected. Like here, we've got it going down towards the margin. And zooming in, we can see the tumour go up against this blue ink, and it also shows cautery artifact or diathermy artifact where it kind of gets shriveled up. In those cases, then we go back to the macroscopic photos and note which slide it was taken from, and then we can find the region on the specimen where that close margin is. And then we can relay that back to the surgeons so they know whereabouts on the specimen that was involved in case that they want to take any extra margins. It is important to note though, particularly around the border of the tongue and getting towards the floor of mouth, sometimes there is nectar section which is taken from that region and it's just sent in a separate pot. So if you do have a margin around there, it may not be a true margin. So it can be really helpful for pathologists having a bit of nectar section attached to the main tumour specimen. So we can see that here, we've got the tongue with tumour, and then we've got submandibular gland and level 1B. And so that really helps with the margin assessment, having that little bit of nectar section attached there. Another pitfall when measuring margins is tissue contraction from fixation. So the oral tongue, it holds its shape fairly well because it has a lot of muscle within it, but the floor of mouth, it has this really loose stromal connective tissue here, and it can really tend to contract up quite a lot. And sometimes you see this kind of concertina effect where the mucosa is all kind of crumpled up from being contracted in. And it really can be quite misleading and make the margin look a lot closer than what it actually is. So it's important to take that into account. And so I tend to go with the contour of the floor of mouth margins when making a margin measurement. In this case, it's to dysplasia, but the same principle applies to invasive carcinoma. So last but not least, lymph node assessment. It obviously impacts the N category of staging. So for lymph node assessment, all of the nodes within a nectar section are submitted. Lymph nodes which are 10 millimeters or greater, they're sectioned into smaller pieces, and smaller nodes are submitted whole. So as far as tumour deposits go, they're usually spotted in the subcapsular space, like in this case here. And so what I tend to do is do a quick once over on low power magnification, scanning for any large mets, and if I don't see any, I don't see any, then I kind of go around on 10 times magnification, circle around the nodes and look in the subcapsular sinuses. And picking up these small mets, it really is just about taking your time and looking carefully. Same as the primary tumour, if the node is macroscopically obviously involved, then we take the macroscopic measurement for the tumour deposit. In a small deposit like this, then microscopic measurements are required. And unlike in some other body systems such as breast, where we do designate whether or not it's isolated tumour cells or a micromet, so isolated tumour cells being a deposit which is less than 0.2 millimetres, a micromet 2 millimetres or less. We're not required to do that with head and neck specimens. Currently there's not much data about head and neck cancers and micromets and isolated tumour cells. So if you do have a deposit of any size, then that node is considered positive. We also assess for extranodal extension. We've got another deposit here. Most of the capsule of the lymph node is intact, but we can see a little focus down here. And zooming in, we can see that there's extranodal extension. Tumour goes beyond the lymph node capsule into the surrounding fat. And so extranodal extension, it's stratified into microscopic and macroscopic. This case is microscopic, and that's where the tumour extends equal to or less than 2 millimetres beyond the capsule. Another focus here where most of the node is replaced by tumour, and we've got tumour here, a lot of fibrosis, and only a little bit of residual lymph node here. And there's a lot of extranodal extension here, quite easy to pick up with the tumour going out into the fat. And so this is a case of macroscopic E&E. So that does it for pathological assessment of tongue cancer. In the live session on the 7th of June, I'll be going over, briefly going over some novel assessments, such as tumour infiltrating lymphocytes, as well as PD-L1 immunohistochemistry assessment. So thanks a lot for listening. I really hope that this has been helpful, and hope that it's given you a better understanding of tongue cancer assessment.